There were no gloves in those days. And he realized that something was being transmitted to the women from the autopsies. And he decided that the smell from the autopsies was so bad that he wanted to do something to get rid of it. And he came up with this idea of chlorinated solution, just chlorinated water. And he got permission, and he had the students and the doctors wash their hands in this. And over the course of time, the mortality rate dropped dramatically.
Hey everyone, welcome to Humemed. I'm Dr. David Spiro. This is the space and place where doctors talk about, and healthcare providers and folks in healthcare that talk about the moments that change them. We talk about the emotional, moral, and human realities of medicine. Thanks for being here. Please hit subscribe. I'm incredibly delighted and honored to have Dr. Barry Davis with us today. He's a physician scientist and clinical trialist who helped shape modern cardiovascular prevention. He held leadership roles in major hypertension trials, including ALLHAT and SHEP, and is the author of The Preventioneers, a narrative history exploring why societies delay action on early warning signs and what it takes to prevent crisis, which is fascinating, and we're going to get into that. Dr. Davis provides evidence-based insight on prevention, public health leadership, and the persistent gap between knowledge and action. Barry, welcome to the show.
Thank you, David. Glad to be here.
Yeah. So tell us about your story. You obviously have written a book, and which has many chapters in different aspects of prevention, which is where we're trying to get to here, which is thus the title, correct? Did I say it right? Preventioneers?
Right, Preventioneers.
Preventioneers. I'm so sorry. So tell me a little bit about the title. What inspired you to write that title and get into that?
Well, after writing the book and gathering all the stories about all these people involved in prevention, I was trying to come up with a title, and I was thinking, well, these were prevention pioneers. And I said, well, I could call it Prevention Pioneers, but why not shorten it? Call it Preventioneers. So that's what I like.
I love it. I love it. I love it. So tell us a little bit. I want to get into the story. I really am very, very interested in the story. And then I want to talk about the link between the various stories and sort of some of the wisdom that you can share with the audience about preventative health, which is so important.
Right. So what inspired me to write the book was the beginning of the COVID pandemic. And I got to thinking about, well, we know how to prevent things, and why aren't we doing something more than we had been doing? And I came back to this quote has been living with me my whole life, the quote from Benjamin Franklin, an ounce of prevention is worth a pound of cure. And I was thought, well, that should be on the front of every school of public health. But then I delved into it and found out that Franklin was not talking about medicine. He was talking about fire prevention. So I thought more about that and said, well, maybe there's a connection between this and others, and there definitely is. And I decided I was going to write a book about not only Franklin, but others who were involved in prevention. So the story continued beyond Franklin, include people like Ignaz Semmelweis, Sarah Josephine Baker, Edward Fries, who did the VA cooperative trials in hypertension, Richard Dahl, who's well known for his work in cigarette smoking and cancer prevention, and others. And finally, I got to climate change, which was the ultimate end of the book. It was sort of an arc from fire prevention to climate change and the planet on fire.
So did you want to spend some time today talking about the story of Semmelweis? Because I remembered it when you had mentioned it to me, but I think it's a fascinating story, and I would love to delve into it a little bit.
Yes, it's an incredible story. If you'll allow me, David, I'd like to just read the first paragraph of the story.
Please.
Okay, so here's the book. But it's the subtitle of it is called For Whom the Bell Rings. A bell rang in the corridor. The hospital ward fell silent. The patients froze. The priest entered, followed by attendants carrying a body. Dr. Ignaz Semmelweis recalled the terror of this all-too-routine ritual. The victim was a woman with childbed fever, a disease whose cause is still unknown. But the bell also told for Dr. Semmelweis. He resolved to do something about this disease. So he was an obstetrician, and he was involved in this institution called the Vienna General Hospital. And he started there, and he noticed that all these women were dying in childbirth, but that wasn't unusual because there were a lot of women dying in childbirth all across Europe. But
And at that point, and if I don't know if you know the statistics, but it right now the mortality with childbirth is less than 1%, I believe. Back then, it was 5%, 10%. It was high, wasn't it?
extremely high. It was one of the books they say that like over 1 million women have died across Europe during the 1800s because of it.
Wow.
But he was in an unusual institution because they kept records, meticulous records of mortality rates. And it turns out that there were two clinics that were sort of side by side. And one clinic was manned by the nursing students. They took care of the women. And the other clinic was manned by the physicians. They were all male physicians in those days. And the difference between the rates of mortality in the two clinics was very dramatic. In fact, when women came to the Vienna General Hospital, they wanted not to go to the doctor's clinic. They wanted to go to the other clinic because they heard so much bad things about it. But what happened was he wanted to investigate why this was happening. Couldn't understand why one clinic had such a low rate and the other clinic had a high rate. What was the difference? And he came up with a series of questions. And he went through them meticulously, one by one by one. The theory of the day for the mortality rate was that there was this thing called miasma, which was like the vapors in the air. And people thought that that was causing it. And it was a well-known theory, and most physicians of the day subscribed to it. There was nothing known about germ theory in those days. They had no idea. So he investigated, went through various things. Maybe the doctors were too rough, and the midwives, the students that I talked about, they were not. Maybe there was something in the diet. Maybe there was something in the bed linens. He went through everything. He couldn't find out anything. And finally, he sort of just gave up. And he went on a vacation. And when he was on vacation, one of his mentors died. He came back. He was shocked. What had happened? And they did an autopsy on this mentor, and he realized that he had died in the same way that these women had died. And it was like a light bulb went off in his head, what was causing it. He knew that in those days they had this, since so many women had died, but they did a lot of autopsies. And the doctors would go to the morgue and they would do the postmortems. And they wouldn't necessarily wash their hands. And if they did, they'd wipe them off with a towel, or they'd just use like soap and water. And then they would go on back to the clinic and examine the women. There were no gloves in those days. And he realized that something was being transmitted to the women from the autopsies. And he decided that the smell from the autopsy was so bad that he wanted to do something to get rid of it. And he came up with this idea of chlorinated solution, just chlorinated water. And he got permission, and he had the students and the doctors wash their hands in this. And over the course of time, the mortality rate dropped dramatically. It was like down by 90%. And here he had this solution to the problem. He called the transmission cadaverous particles. Again, they didn't have any germ theory in those days. So he went on to propose that they do this. And they said, well, you need more evidence. You need to collect more data. You need to do animal experiments. He said, okay, and you need to publish your results. He said, okay, but he didn't publish his results. He met some resistance within the institution. Some of the doctors there did not like what he was saying. for a number of reasons. One of them was it was against the theory of the day. As I said, the theory of the day was this miasma, or I called it in the book prevailing winds, just what was in the air. And he realized that that couldn't be the case. He had already thought about that. If that was what was in the air, then why would it sit in one clinic versus the other clinic? They were right next to each other. But he said, oh, okay, well, I'll do what you want. He did an animal experiment, and it wasn't good enough. For some reason, he didn't publish right away. And I go into great detail in the book about why. But the other thing that bothered people was he's basically telling the doctors that they're unclean. They didn't want to have any part of that. And also, he was young. He was a junior person. He was Hungarian. He wasn't from Vienna in Austria. So he was sort of an outsider. And they just didn't listen. Other people did listen to him. It's amazing. Some people thought his contribution was as great as Jenner's, who came up with the smallpox vaccine. Others didn't think anything of it. Eventually, he was forced out of his position. He had to go back to Hungary. He worked for years. He finally published. And others across Europe, some people listened to him and thought he was right, but most didn't. And he ended up in an insane asylum, and he died at the age of 47.
Wow, that's very sad. So I want to get back to the beginning part of the story. You had said that there were two clinics. One was run by a nurse and one nursing midwives, and the other were physicians, and there were different mortality rates.
Yep.
And the mortality rates were lower with the midwives
Yep.
because they were not doing the autopsies. Is that sort of putting it together?
So
and he noticed that.
Oh,
like he
was very, very
Interesting.
methodical about how he approached it. He came up with a series of questions about what could be causing it. And he couldn't come up with a solution until that, as I said, his friend died, and then he realized what was the cause of it.
Well, what made him, so there was miasma, the prevailing theory, which obviously it's not vapors. There are viruses in the air, and you can transmit things through the air, but it's not vapor. It's obviously part of what's well established as germ theory. This was the mid 1800s, is that correct?
1850s. Actually, it was 1840s, late 1840s.
Okay, so it's interesting because if you look at a film that is either documentary or fictional, fictionalized history as much as you can, it's very uncomfortable seeing physicians operate. For me, seeing physicians operate on patients, even in the early 1900s, without gloves. Right. Just the idea of touching a patient. And it's funny because since COVID, I'm a pediatric ER physician, and since COVID, I walk into every room with a glove and a mask. I see a lot of infectious diseases. We see RSV, we see COVID, we see influenza. And what's been interesting, Barry, over the course of the last few years, I feel like, at least for myself, and I believe with my colleagues, we are getting less sick because we have a barrier of protection when we walk into a room. And now when I walk into a room without a mask, I feel slightly uncomfortable. And what we found, correct me if I'm wrong, you know the data better than I, but when COVID came about, it was very clear that masks and gloves prevented transmission of disease. Is that fair?
Yes, that's very fair. It had to be the right kind of mask, but yes.
Yeah. So I'm curious. I want to get into, now, back then people died of or people were put into insane asylums for lots of different reasons, but there was syphilis, and there were medical reasons why folks became psychotic and not able to matriculate into society. Do we know exactly what happened and why he went crazy and
Well,
what
he
actually
didn't exactly go crazy. He was just he had gotten married recently, and I think his obsession with this whole that nobody believed him and his theories and that, as I've said, he published this big treatise on it, and his lack of acceptance, he became a little bit obsessed with it. And his wife felt that he should, have some rest time, be put in an asylum for a while. But something happened when he was put in there. Apparently, for one reason or another, he was beaten up by the attendants.
oh, it's horrible.
And he sort of died of the same thing that he was talking about. He became infected, and that affected him.
So, do we know now what sort of infectious process came from? Were they gram-negative bacteria? Do we know what the infectious agent was, or can we only surmise at this point?
From all my reading, I don't think that it came across, but I think you can surmise pretty well that it was, just a postpartum infection. I don't know the exact bacteria, but it probably was.
Mm-hmm, mm-hmm. So, what did you glean from this particular story and many other stories that you wrote in your book about people in healthcare who go against the grain?
Yeah, well,
What?
that's a great question, David. What I didn't realize at first, I was just sort of gathering story. The fire prevention, and then Semmelweis was an easy one because you wash your hands. But then I started to gather more stories, and I realized that there's this pattern. There's this incredible pattern, and each of them would go through this. And some of them were successful all the way, and others not. But it was basically they would see something in their work or where they lived that was causing harm. So in the case of Franklin, he was exposed to fire at an early age, and he lived in cities where there were fires, big fires. And obviously, Semmelweis he started his position at a hospital, and women were dying. There's a chapter in there about the auto safety doctors, I call them. These 5 doctors, among many others, who saw in their practice their patients were being harmed by auto accidents. And there was a plastic surgeon, there was a ENT doctor, there was a neurosurgeon. So you see all these aspects of auto injuries. So that they recognize that there's this preventable, well, there's this harm, and then they think, well, can this be prevented? And they all came up with some kind of solution to how it could be prevented. They recognized that there was something there to do, but then they would have to translate that. How do you translate what I know about this to some sort of action? And then the go from there is how do you create the action such that it's institutionalized or put into place so that it becomes either part of the norm or standard guidelines or part of the culture. So, for example, in the case of auto safety, it took a long time before the car companies agreed to institute these things. But then, even when they put seatbelts in cars, look how long it took for people to actually use them. You had to have laws which sort of not only encourage but force people to use them. I mean, you still see
Right. And by the way, if you live in Arkansas and you're a pediatric ER physician, that's me, and you take care of teenagers in Arkansas who are seriously injured with motor vehicle accidents, the vast majority of children who are seriously injured are not wearing seatbelts. It's like dumb stupid to not wear a seatbelt when you get into a car. And it's so annoying, right? Because now when you get into a car and you drive down the road and you don't put your seatbelt on, like I live, Barry, about 8 homes away from a central mailbox in our neighborhood. And I will sometimes be lazy and say, I'm not going to put my seatbelt on the 5 miles an hour it takes in 30 seconds to get from the mailbox to my house. But it is such an annoying beep that I put it on. and it's the right thing to do,
Oh, yeah. Yeah.
because I can get into an MVA in my neighborhood. Not wouldn't be thrown from my vehicle because teenagers are doing stupid things. But to your point, there are that kind of preventive measure dramatically reduced the mortality and morbidity of disease around motor vehicle accidents. Correct? Didn't we see that's a classic public health slide where you actually see a decrease in the number of motor vehicle accidents after we passed those laws in the 1970s.
Yes, yes, it was dramatic. But the thing was that these five doctors, they came to realize that people get into accidents. I mean, the prevailing theory of the day was, well, it's all the individual's fault. They're not driving correctly. They're not paying attention. Some of that's true, but they realized that the car design could be changed dramatically to help lessen the injury rate. And if you do have injuries, they would be less severe. So they came up with these ideas. I mean, these doctors not only did they come up with the ideas, they actually some of them redesigned their own cars.
Interesting.
They created a different kind of dashboard. They padded the dashboards. In those days, they had all these buttons that would come out, and the steering wheels were just terrible. They even crash into them. They wouldn't retract or anything. In fact, even in the very early days, before these doctors came along, there wasn't even safety glass in the cars. And people realized that, you need safety glasses because people would just go through the windshield.
Well, quick shout out to Dr. I want to make a quick shout out to Dr. Greg Goldbranson, who actually was on the show here about 2 months ago. And he is a pediatrician in New York who had a horrible experience. I don't know if you know who he is, but he ran over his child.
Yes.
And he went to Congress, and now there's a law around rear view cameras in every car that's sold in the U.S., and that has dramatically reduced the incidence of bad events when you're backing up and you're blinded to what's actually happening in the back, especially if you're a toddler. Yeah, it's so interesting, Barry, because I'm a child. I grew up in the late 60s, early 70s. And I remember when I was 3 or 4 years old in the late 60s, my dad had an Oldsmobile, older car, right? They don't make them anymore. And there was a thing that was sat in the middle of the row, in the first row, like a little cushion that came down. And I would sit on that cushion and we'd be going on the parkway. And if he, God forbid, were in an accident, I would be flying right through the windshield. Yeah, and that was just, it wasn't even a thought back then to have seatbelts.
Yeah, I mean, so that was this is all, as I said, the pattern. They realized, along with in the other chapters, other people realized there were harms being happening, that some way you could prevent these harms, and then you had to be able to convince others of how to do this. Somehow it has to become part of the institution or a guideline or a norm or the culture. It took a long time in the case of seatbelts before it just became so automatic. I mean, when it first came out, they just put them in cars. People didn't use them at all.
Yeah.
They would sit on them, or they do so. But it took a long time before they realized, well, they put that annoying beep in there so that you're reminded about it. And then, it became laws. If they catch you without a seatbelt, they can ticket you. So it was one thing after another. So this is to protect you, protect society.
Yeah. Well, you have a doctorate in public health, and maybe you can problem solve with me in front of my whole audience. Maybe some of my colleagues are listening, and I may get in trouble, but I have tried to challenge healthcare. I went to a medical school in San Francisco, which challenged me as a medical student to question dogma. And I went to college. I went to med school at the University of California, San Francisco. And my first lecture, the dean said 80% of what we teach you is either going to be wrong or outdated over the course of your lifetime. And it's probably 90%. But what I'm dealing with in the emergency department is there's been the concept out of convenience. A lot of things have been developed, Barry, over the course of medicine for the convenience of the physician. For example, clinics and hospitals were built to aggregate patients so physicians didn't have to move around, right? Because in the 1920s, physicians who were pediatricians like myself, emergency medicine didn't even exist back then. We would be going to homes and visiting people in house calls. That's what physicians did. But and babies were born in homes back then, and in the 1800s, of course, but not all, but many. So what my challenge has been is I have always, and my mentors have taught me this, I've always really questioned the idea of the waiting room. The waiting room has been this concept in emergency medicine that has existed, and it has always made me feel uncomfortable. And for many years as an emergency medicine doctor, peds ER, I would disassociate myself from the waiting room. I would just focus on what was in front of me, which were the patients that have been brought back from the waiting room. And the waiting room is just like, well, whatever, what's going on there. And it turns out that the waiting room is the most dangerous place in the hospital at any given time, period. And in every single hospital in the U.S. And the concept of the waiting room is there's a wait. And so what we've been doing at our hospital is we've been putting nurse practitioners in the front of the ER. So we've renamed the waiting room Fred, like Fred Rogers, but Fred stands for the front of the ED, FRED. And we have nurse practitioners out in the front. And lo and behold, by doing that, and they see lower volume, lower acuity patients, and then they get discharged from the waiting room back out. And a couple things that we've noticed. One is there are less people waiting. Number two are left without being seen. So patients that show up, get frustrated, and then leave went from 12% to 3%, and maybe even less than 3% this year. And then we've noticed that just the general happiness and the satisfaction of the families have gone up. And the other issue from your expertise and your background from a preventive health standpoint is that we know, based on germ theory, when you put people in a very closed space, they transmit disease. And so we're providing a milieu that's the antithesis of healthcare, which is this concept of the waiting room. But I was curious because I would love your advice. It took a while, but we, our nurse practitioners now actually enjoy it, and we're redesigning the waiting area, the front of the ER. But what's really interesting is that I'm receiving a lot of pushback from some of my physician colleagues, because we've also found when physicians are out in the front of the ED, magic happens. What's that magic? We end up ordering tests earlier. Things get done quicker. Patients get seen faster. And many of the patients who are maybe thought of as sick that are really not sick can just be discharged right from the front of the ER and never have to go back. And we also know that it's 5 steps to get a patient out of the ER in the front, and a minimum of 15 to 20 steps, or maybe 30 or 40 steps in the back of the ED once you bring them back.
Can I ask
what advice do you have?
I want to ask you what kind of pushback? Why are you getting pushback?
I think it does sound good. I think that the most important job in the ER in any given moment is not a physician. It's actually the triage nurse. And the front of the ED is chaotic, and the back of the ED is less chaotic. It can be chaotic in the back, but generally speaking, it's controlled chaos, where the waiting room is very, very chaotic, and it's stressful. It really is a more stressful environment. Now, I will tell you that I personally love being up there because it's therapeutic for me to see patients and discharge them quickly, where I'm sort of handcuffed in the back because of processes that are in place that just slow the throughput of families. And I love efficient care when I can deliver it. So I think it's the idea, and it's interesting. One of my colleagues who I trust and really value his opinion, he said, well, I went to medical school and I became a peds ER physician not to go up to the front of the ER and see patients and discharge them from there. It's almost like it's challenging the concept of what people thought it would be to be an emergency physician and what their life would be like. And the reality is I can't put all the physicians in the front of the ER, but I can put one at a time, along with the nurse practitioners. The other thing, so what are your thoughts about that?
Well, okay, so I was going to say, you asked me about this, am I going about the
Yeah.
path in the book? But one thing that was throughout every story is this resistance. Resistance came in many forms that people got pushback. I already talked about Semmelweis' resistance. Franklin got resistance too. He was trying to institute sort of preventive measures for fire prevention. And the people in the city said, well, it's going to cost too much to do all this stuff.
Ben Franklin.
Ben Franklin. Uh, there's resistance in the auto safety. Well, you got resistance from the car companies. They say this is just going to cost too much. People are not interested. The last chapter is about climate change. You can realize the amount of incredible resistance we've gotten over the last 40 years to climate change. People question the science, which 97% of the scientists agree with this. But there's been resistance. The biggest one, I guess, maybe was the tobacco industry, the chapter I have about smoking. The tobacco industry fought tooth and nail all along the way. So whenever people are comfortable in how they do things, they don't like changing the status quo. And if you come along and come up with some theory or some way of doing things, which in the long run may be better, if it changes with the way they do things, they don't like it. So I think that's the kind of thing that you're bumping up against. And it's a question of having to prove that in the long run, it's better for everybody concerned, even for the physicians there, because they can either do other kinds of things, which may be more productive, or somehow figure out other ways to make the whole operation more efficient. But it is tough. You always meet resistance.
Hmm. I think that it's interesting because I feel like in some degree, I've been a little bit of a change agent within, the small little things that I can change in my life over time. But there have been times in my life, like we built a pediatric ER in Oregon at the medical school that didn't exist before. And challenging status quo is uncomfortable. And and it's just uncomfortable, and it feels almost yucky to be in a situation because most of us go into medicine to help others. We're people pleasers. Not everyone, but many of us do, and it just feels uncomfortable sometimes when you have good data, and you have it's not just a feeling. It's not like let's just go up the hill and see what's on the other side. You know what's on the other side because you have good data. But convincing everyone to sort of run up the hill with you is hard. Do you think with Semmelweis, you had talked about in Vienna, which I believe was one of the centers of essentially Western civilization at that time, of
Oh, yeah.
culture and medicine and art, all it was sort of huge. And why was Semmelweis so resistant to publish? Was it because he was Hungarian and didn't feel comfortable publishing in German? What was the resistance for him to publish?
That was one of the reasons. Uh, he tried um, to gather his data, but he had all this advice from other people about you have to do more experiments. So we tried to do that, and they didn't like that. And they said basically in those days there was no thought of clinical trials. That wasn't around. That wasn't a theory. But they had an idea that just because you did something and it changed things, that what you did was not necessarily the cause of it. But they didn't tell him how you should go about to prove it. They just mentioned that this, and they were right about that, but they didn't offer any advice. And when he finally did try to publish, after he was kicked out of Vienna, it was extremely hard because back in Hungary, there was a revolution. The science journals sort of went away for a while. So he was fighting an uphill battle there. But what I was going to go back to, David, one of the most interesting things that you talk about there is more relatable to the next chapter in the book, which was about Sarah Josephine Baker, who was a physician in New York City. She became head of the Child Health Hygiene Bureau in New York City. And she came up with all these ideas to prevent child mortality
What year was this?
in the early 1900s,
Mm-hmm.
just at the turn of the century. And the physicians complained about her because she was having this operation in New York City, and they said, you know, the patients aren't getting sick. We're not being able to see patients anymore. She's ruining our business.
Mm.
So as a physician
Interesting.
who were complaining that, you know, she was keeping children healthy and they weren't seeing sick children anymore.
Well, it is interesting. I mean, I do believe that the vast majority of my colleagues I believe that they are trying to do the right thing. And something that struck me when you say that is that at least in the U.S., there's the business of medicine. And so there's payers, there are financial transactions that are occurring. My best friend lives in Eastern Europe. He lives in Prague, and he took his kid to the ER with an ear infection. And it costs him $3 to be seen by an ENT physician in the ER and $6 for the antibiotic. So the whole experience was $9. And now you can't come to an ER in the US without a $500 to $1,000 visit, even if it's for a toenail infection. So we, you know, there is that aspect of healthcare that I don't know what your thoughts are, but I do believe at some point in healthcare it will ultimately be free as we become more evolved, and it'll just be part of what we do as society. And medical school will be free, and but I don't know. Do you have any
No,
thoughts
no.
about that?
Oh, yeah. So part of the reason for writing the book, I mean, I like to tell stories because people usually are more interested in stories than they are in data.
Well, that's why we have Humemed, right? For you to
Right.
come on and tell a story.
Exactly. So people are more interested in stories. But, you know, there's only 3% of the research budget is spent on prevention. All the rest is spent on after prevention.
Mm-hmm.
You know, if you think about, I go over all these things, it's just dramatic results. I mean, one of the other things, and this is where my territory is hypertension. Um, you know, we have all these great things to do for hypertension. You find out somebody has hypertension, you can put them on lifestyle, which usually doesn't work, but okay. You can put them on some basic medicines. But the problem is that people are not in control. I mean, every time I
Mm-hmm.
see a study, I studied several years ago, was saying that only 25% of the U.S. population is under control. And now it's become only 20% of the U.S. population that has hypertension is under control. So, I mean, it's just incredible that we just would be able to move the needle to prevent even more heart attacks, strokes, heart failure. And it's the same thing for a lot of the things, even smoking. I mean, the smoking rate has come down dramatically, but we can do so much more.
Of course.
And you said, you know, with the seatbelts, I mean, it should be more improvements, more ways of thinking about it. If just we spend a little bit more money on prevention, we could move the needle.
Yeah.
And that goes basically to the healthcare too. I mean, you know, everybody needs access to healthcare, and we still don't have it.
Yeah, what are your thoughts? Have you looked into, you talked about so many of the major health topics, seatbelts in your book, hypertension, cigarette smoking, uh, prevention of germs being transmitted. What are your thoughts, and have you thought a little bit about what I think is this smoking epidemic of 2026, which is ultra processed foods, and there's a growing amount of data that ultra processed foods are extremely unhealthy for the American public, and I saw some statistic that 80 to 90% of adults are eating ultra processed foods. And I'm curious, what do you have any thoughts on that?
Yes, I have lots of thoughts on that. So the big one of the biggest problems with prevention is trying to push the prevention back on the individual without changing the environment. And most of the stories that I talk about in the book we try to change the environment because at an individual level, it's a losing battle. I mean, the thing with weight loss, all these years, people talked about, well, just exercise more and go on a diet, exercise more and go on a diet. Well, look what happened. There's a huge industry for the exercise industry and for the diet industry and all that. And then along come the GLP-1s and things are changing, but people couldn't do it. Um, so it's the same thing with ultra processed food. You can't tell people to stay away from that. It's in everything. Somehow the food industry has to change. This, I talked about in the book, there's big oil, big tobacco. Um, well, there's big food. I mean, somehow we have to get the legislature, other people. I hate to be like this because it looks like a nanny state. But if you do this, you'll protect the health of the population.
No,
It's just incredible. Individually, we can't deal with the ultra processed foods. Individually, we can't.
but I'm not a conspiracy theorist. I don't believe, but I do believe that there are certain things to be true, and um, producing ultra processed foods are, number one, inexpensive for the general population, and number two, it's a big industry. And I'm sure they have a huge lobbying effect in Congress and here in the U.S. And then we have the farming industry that feeds into it, and so it's really and one of the things, I'm not a huge Robert Kennedy fan, especially around his views on immunizations, but I also don't see most things as black and white. There's a lot of gray in most people, and I think that he has some really good ideas about improving foods in hospitals and reducing the amount of ultra-processed foods that we have. But I will say it's very interesting because even amongst my physician colleagues, I do not eat any processed foods. My wife and I are eating organic foods that have very few ingredients, and I have a shake every day that has just healthy organic foods that go into it, and whatnot. But I will come into work every when I work a shift. I will come in with a lunch bag, and it will have an apple and some carrots and some protein source, and the food that is circulated, brought in, and exists for patients and in vending machines, it's all ultra processed. That's sitting in the hospital. To me, that's insane, and it's funny because people don't make fun of me. I don't feel uncomfortable about it, but I definitely, folks, notice that I am not eating like the vast majority of people. And where's the disconnect there, Barry?
Well, several disconnects, David. I mean, first of all, I'm sure just like me, you're highly educated, you know all this stuff, you're also well off. but you can afford to take the time and the cost of this stuff. Most of the population, I'm sure that you've seen in VR, like these people are just trying to get
Yeah.
day to day. They're not going to worry about, can I get a fresh apple or a carrot or something?
Yeah.
You're going to buy the soda off the shelf or the candy bar or this and that.
Or McDonald's. Just going to
Or
McDonald's.
McDonald's.
Yeah.
Or McDonald's.
Mm.
So that's why I keep on saying that leave it to the individual. It's a losing cause. It has to be done upstream somehow. I agree with you totally about this. It's sort of like, well, we do all this high-tech medicine and all this stuff, but in the hospital, you have this vending machine that has candy bars and all this
Yeah.
stuff. So it is sort of crazy.
For a while, I was traveling between Portland, Oregon, where I lived before, and here in Little Rock, and I would be going through Denver, and just like with Semmelweis, and noticing the midwives and the physicians and the different mortality rates in the clinic. When I stopped off in Terminal B, I forget what it was, at Denver International Airport, in the center section, there were two places to get food side by side. One was Chick-fil-A, and the other was a salad thing, Greek salad area, where it was mostly healthy food. There was a line always to get the Chick-fil-A off the, like, multiple, 20-minute wait, and right in to get the salad bar that didn't have all the fried food and the ultra-processed foods. And just like looking back at that meta, it's like, okay, this is the experiment right here, just like Semmelweis. It's like, the general population has not yet adjusted to the idea that this thing that they're putting in their body will ultimately make a difference. And I think in regard to all the different things that you talk about in your book, like hypertension, the silent killer, with ultra-processed foods, we don't necessarily feel the difference when we're on it. Although now, when I do have processed food, I don't feel great. Like I feel differently, but you get used to the feeling of being on ultra-processed foods. So
when you're on it, it's great. They make it taste great. You get all that.
Yeah. Yeah. And processed sugar is addictive. That it is just as addictive as nicotine, maybe even more.
Right, right. But again, leaving it up to the individual is incredibly hard.
No. Well, this has been an incredibly delightful conversation. I'll sort of end this by how I started. It's an honor having you on the show, and thank you for trying to solve my own problems in my own pediatric ER, selfishly. But what if you could share as we conclude? What are one or two, and you're a professor like I am, you teach, what are one or two seminal teaching points that you would like the audience to take home from this massive amount of knowledge that you've learned around the Preventioneers?
I'd like people to have a prevention mindset that in your life and everything that you do, you should sort of think about, can this be prevented? Can this be stopped in some way? We do this in our lives all the time. You take care of your car. You do all this preventive maintenance on your car. You take it in for an oil change or other kinds of things. You do it in your house. You change the filters. You change the light bulbs. You do all these things. And we do sometimes, hopefully, for our health. People get their kids vaccinated. They get vaccinated. They watch their blood pressure. They know their numbers, their cholesterol, and all that. But there are so many other things in life where you could think of things that, can I prevent this? Can I, should I put this off? Or can I do something today that would help me in the future? Because the bottom line for prevention is it not only does it save lives and protect health, but it also reduces costs tremendously. If you do something upfront rather than wait for disaster to happen, you can save so much money.
Where can our audience get a copy of Preventioneers? Where can we get a copy of the book?
You could get it on Amazon. You can get it at the publisher, Johns Hopkins University Press. You can get it at Barnes and Nobles. It's not going to be literally out until May 5th, but you can pre-order that.
Oh, wow. So yeah, I'm definitely going to read this book. This is, I love reading history, and yeah, I can't wait to read the book. And again, it's been an honor to have you on the show. Thank you for taking time out of your day, and also congratulations. I think writing a book, I've written chapters for people, but writing a book is an extensive amount of time. And as someone who's massively interested in this topic, thank you for writing about it. I think it's important. I think there's so many important things that we can learn, and I hope my audience buys a copy of this book. I certainly am when it comes out. We're recording this in mid-April, and so in a couple weeks, by the time this is published, we'll be able to get this publicly on Amazon. Will it be on Kindle? I just bought a Kindle little thing for night.
Yeah. Oh, yes. Yeah.
Yes, because that's my new thing, because don't like.
Yeah. I like ebooks too.
Yeah. All right. Well,
thank you so much.
Of course. It's been a pleasure and an honor. And for those of you that are listening, please, thank you for listening. And please subscribe on YouTube, Spotify, Apple, wherever you get your podcast information. This is Dr. David Spiro. I hope you all have a great day. Bye.
Thanks for listening to Humemed with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.